to each lecture, I will be the first speaker talking about comparison of contemporary European and American hypertension guidelines. If I can have the disclaimer slide. Each speaker I will be introducing prior to their lecture. Dr. Narita will be introducing the last two speakers. May I please have the disclaimer slide? All right, so the content of this webinar is copyrighted by the APSC and should not be distributed. The views and opinions expressed in the webinar are those of the faculty members. We do advise that this live streaming content be made available via several avenues so that you can review and watch. So let's get started. So I will be the first speaker. I am Lourdes Ella Santos from the Philippines, a clinical associate professor from the Philippine General Hospital. I am actually the incumbent president of the Philippine Lipid and Atherosclerosis Society in Manila, Philippines. And I am very excited to start my lecture, which, if I can please have access to sharing my slides. For the first lecture this morning, entitled Comparison of Contemporary European and American Hypertension Guidelines, particularly comments from me, an Asian Pacific physician practicing in the Philippines. So this is the outline of my lecture this afternoon. We'll talk about blood pressure cutoffs, the implications of concomitant risk factors among patients with hypertension, treatment options, and the impact of international guidelines, particularly of the American and the European guidelines on the Philippine guidelines for the management of hypertension. So we'll start with knowing the numbers. So I think the most striking difference between the ACC/AHA and the ESC guidelines for the management of hypertension really is the fact that there was a change in the cutoff for hypertension diagnosis, where in 2017, the ACC/AHA rocked the hypertension world by saying that hypertension cutoff be 130/80 as opposed to the usual 140/90. And in their 2017 guidelines, stage 1 hypertension was classified as patients with BP of 130 to 139 over 80 to 89. And those patients with a blood pressure of more than 140/90 now reclassified to a higher stage 2 hypertension. And the reason why the ACC/AHA chose 130/80 as the cutoff for hypertension is the SPRINT trial. So the SPRINT trial was a clinical trial that looked at intensive versus standard blood pressure control. In this trial, they were able to achieve BP readings of less than 130/80 in the intensive treatment arm and 140/90 in the standard treatment arm. And in those patients that achieved a blood pressure of less than 130/80, there was a statistically significant reduction in primary outcome for cardiovascular events, with a 25% relative risk reduction and a very small number needed to treat of 62. On the basis of the SPRINT trial, with patients with 130/80 reaching the primary outcome, came the recommendations of the 2017 ACC/AHA to have 130/80 as the cutoff for hypertension. The following year, the ESC came out with their recommendations for hypertension management. And you can see that in the 2018 and the 2023 European recommendations, they stuck to 140/90 still as the cutoff for the diagnosis of hypertension. They maintain the grades of hypertension, grade 1 being 140 to 159 over 90 to 99, grade 2 being 160 to 179 over 100 to 109, and grade 3 being more than 180 and more than 110 millimeters mercury. And the reason why the Europeans kept 140 over 90, one of the reasons was because they felt that the sprint trial's BP measurement was different from what is usually done. In that, in the sprint trial, which was the basis for using 130 over 80 as the cutoff in the American guidelines, unattended out-of-office BP can actually impact blood pressure in that you may have lower blood pressure readings just on the basis of an unattended out-of-office blood pressure. So that they released this statement in 2018 that the basis of the sprint trial with BP readings less than 130 over 80 as goal attainment discounted the white coat effect, and it wasn't really comparable with other clinical trials. So in the ESC recommendations, office BP is still recommended for the diagnosis of hypertension, and that this be performed in standardized conditions. Other grades of classification of hypertension include isolated systolic hypertension and diastolic hypertension among the European recommendations. They also included in the 2023 European recommendations patients with hypertension-mediated organ damage, diabetes, CKD stage 3, 4, or 5. And this tells us that now international guidelines are looking at concomitant comorbidities for risk stratification. This is very similar to what the 2017 ACC-AHA guidelines came up with, where if you have a stage 1 hypertensive, regardless of the cutoff, you need to be able to estimate that hypertensive patient's 10-year ASCVD risk in primary prevention. And you only have an impetus to treat with pharmacologic therapy if their 10-year ASCVD risk is more than 10%. So this emergent role of comorbidities in hypertension management for total CV risk assessment was seen in the 2017 ACC-AHA guidelines. This is their ASCVD risk estimator, where by plugging in values, you can compute for that 10-year ASCVD risk scoring. In the 2018 European guidelines, as well as the 2023 guidelines for hypertension, you're going to see very similar risk assessment in their guidelines, where if you have two patients coming into your clinic with the same BP of 140 over 90, if one patient has no other risk factors outside of his hypertension, then he's a low-risk individual. If one patient has 140 over 90 but has established CVD or CKD, then that patient is labeled a very high-risk individual according to the Europeans, telling us that it is concomitant comorbidities that will actually classify your hypertensive patients into low, moderate, high, or very high-risk individuals. And complementary to these concomitant comorbidities is the scoring that the Europeans use, where they've come up with a risk scoring that allows patients to have prediction of their risk in the next 10 years. So it estimates the 10-year risk of fatal and non-fatal CVD, and it's calibrated according to 4 distinct European risk regions. So as opposed to the ASCVD calculator of the Americans, here they actually classified the regions according to those individuals who are low, moderate, high, or very high-risk individuals. They even have an ASCVD scoring in older individuals based on where they come from in the 4 geographical risk regions. And these risk classifications will give you the impetus for treatment strategy. So if we go back to the ACC-AHA guidelines, you're going to see that those patients with a 10-year ASCVD risk, if it's more than 10%, the recommendation is to start them on BP lowering medication. So recognizing the fact that the ACC has a lower cutoff, were more patients treated because 130/80 became the cutoff for hypertension diagnosis. Well, when they looked at studies looking at applying 130/80, they found that compared to the earlier guidelines of the ACC-AHA, even if the cutoff for blood pressure goal is less than 130/80, what they found was they increased the prevalence of patients with hypertension, but the recommendation to place these patients on antihypertensive therapy did not really increase. Because if you take a look at their algorithm, if you have a 10-year ASCVD risk of more than 10%, if the patient has a BP of 130/80 but is labeled low-risk hypertensive, then non-pharmacological therapy with diet and lifestyle modifications is all that is necessary. It is only if a patient is labeled high risk with a BP of 130/80 that BP lowering medication should be started. So although a greater percentage of hypertensives were found with a lower 130/80 cutoff, there was not an increase in the number of patients who were necessarily started on antihypertensive therapy, but it did warrant intensification of treatment. So another similarity between the ACC-AHA guidelines is the fact that in treatment, there is now that recommendation for single pill combination therapy. And this recommends single pill combination choices of an ACE inhibitor combined with a CCB, an ARB with a CCB, or an ACE inhibitor with a diuretic. This is similar to the 2018 European recommendations, where as first-line therapy, there is a preference for 2-drug combination therapy in a single pill treatment strategy for hypertension, with the simplified algorithm of using an ACE inhibitor or ARB plus CCB or diuretic in a single pill. In step 2, triple combination therapy, again, that advocacy for single pill before labeling these patients with resistant hypertension and adding a second pill. The 2023 ESH recommendation, very similar for that advocacy for single pill combination therapy. So I've shown you similarities and differences between the ACC-AHA in that goals are different, yet despite that, the management options as well as risk stratification is very similar among the two. So the challenges to looking at these international guidelines is really its applicability in our local setting. So as a physician practicing in the Asia-Pacific region, particularly in the Philippines, to be able to take these guidelines and to apply it to our patients locally is challenging. And so I was very lucky to have been part of the 2021 Clinical Practice Guidelines for the Management of Hypertension in the Philippines, where these international guidelines served as the basis and we interjected local data so that we could call these guidelines for Filipino patients. And how our guidelines came out is that we come up with clinical questions which we felt were the most applicable among Filipino physicians practicing hypertension management. In the first, you can see our recommendation for hypertension definition, still as a blood pressure similar to the European guidelines of 140/90. That simplified recommendations classifying BP as normal, borderline, and hypertension to make sure that we do not confuse our physicians locally with these particular categories. We have recommendations locally to use devices with a properly validated semi-automated oscillometric sphygmomanometer because of our advocacy for every Filipino to be able to independently monitor their own blood pressure. Of course, for that aneroid sphygmomanometer to still be available for those with arrhythmias or extremes in BP levels. We chose to use this automated oscillometric for proper BP measurement with an advocacy that all local government units be able to take blood pressure of their constituents. When we took a look at blood pressure targets, we worded it particularly where the recommendation locally is to have a therapeutic threshold of 140/90. So that means that locally, if patients are diagnosed or are seen to have a BP of 140/90, to have that threshold to start some form of therapy, whether it is medical therapy or diet and lifestyle modifications, to achieve a goal of less than 130/80. For the very elderly, recognizing that in both the ESC recommendations and the ACC recommendations for higher risk individuals, for 80 years old and above, for frail patients, a therapeutic threshold that is higher, 150/90, to achieve a goal BP of less than 140/90 in Filipino hypertensive. This is the algorithm we've come up with, where in adults with a BP of more than 140/90, cornerstone is dietary and lifestyle modifications, very similar to the ACC-AHA. And we are recognizing now concomitant risk factors such as hypertension-mediated organ damage, CV disease, or CV risk equivalent. Unfortunately, in the Philippines, we do not have an ASCVD risk calculator. So we ask physicians to count risk factors, identify hypertension-mediated organ damage, or establish cardiovascular disease to re-stratify patients into higher risk if they have these concomitant comorbidities. And of course, with treatment options, very similar to our international recommendations, is that advocacy for ideal combination therapy with a RAS inhibitor plus CCB or thiazide-like diuretics. Recognizing again that in the Philippines, financially, some patients may not be able to afford combination therapy since Philippine healthcare is out of pocket, that uncomplicated hypertension monotherapy still be advocated with a RAS inhibitor, a CCB, or a thiazide-like diuretic, with a preference for beta blockers in patients with compelling indications such as coronary artery disease, acute coronary syndrome, high sympathetic drive, and those patients who are pregnant. So those with exceptionally high blood pressure readings, again, that advocacy for combination therapy in single pill. In the Philippines, we are projecting that hypertension be significant in the next 30 years, where in 2050, we do see that by looking at our prevalence data with a 23% that increased to 28%, by 2050, we project that the deaths related to hypertension will increase more than double from 90,000 to 210,000 due to ischemic heart disease, stroke, and chronic kidney disease. And that's why there is a continued thrust for hypertension management and early diagnosis with treatment. So for my part, take-home messages, we know that hypertension remains to be an established modifiable risk factor for the development of cardiovascular disease. And this is evident in both our international guidelines, the ACC-AHA, as well as the ESC-ESH locally too. Several guidelines have emerged on the diagnosis and treatment of hypertension. The European and American guidelines have released evidence-based recommendations, which have both significant similarities bound by evidence as well as differences. We know that the value of these international guidelines actually aid in the creation of local guidelines in the Asia-Pacific region with an encouragement for creating guidelines that are distinctly our own. Thank you very much for listening, and I will introduce the next speaker. So the next speaker for this session is, let me just get my Dr. Siska Danny from Indonesia, who is the head of the Intensive Cardiovascular Care Unit of the National Cardiovascular Center, Harapan Kita, Jakarta, Indonesia. She's the coordinator of Acute and Intensive Cardiovascular Division, Department of Cardiology and Vascular Medicine, Universitas Indonesia, and Jakarta, Selatan, Indonesia. She's going to be giving us a lecture on the management of sustained hypertension, white coat hypertension, masked hypertension, and resistant hypertension, a systematic choice of pharmacological therapy. Let's welcome Dr. Siska Danny.
Hello, hi everyone. Good morning. It's still morning here in Jakarta. I understand it's afternoon in some other parts of the audience. And thank you, Dr. Lourdes, for the kind introduction. Let me just put up my slide. Sorry about that. I hope the slides are on. And okay, let me start by thanking the organizing committee for the wonderful initiative to bring forward hypertension management as a common goal in Asia Pacific region. I am honored to join the well-known experts here. Greetings from Jakarta, and I hope this collaboration could continue on other sessions too. And continuing from the previous lecture, I was tasked about to talk about the management of white coat, masked, sustained, and resistant hypertension. And I think it's quite a challenge to put in so many aspects on a 20-minute lecture. So I hope I'm up for the task. I have no displeasure related to the current presentation. And let me start with the fact that blood pressure, we know, is a highly variable entity. And not long after we are able to recognize that high blood pressure correlated with heart diseases and stroke, it was also observed that blood pressure could vary greatly, not just day-to-day variation, but even in heartbeat to heartbeat. And in the 1940s, Amen and Goldshine demonstrated that the average blood pressure readings were around 30 millimeter mercury lower at home than in the hospital or clinic blood pressure. But due to lack of better measurement technique, clinic or office blood pressure at that time was still regarded as the gold standard to diagnose hypertension. And the shift in paradigm, I think, started to occur when in the 1960s, Sokolow and Hillman developed the first semi-automatic ambulatory blood pressure recordings and demonstrated variability of 20-hour blood pressure with poor correlation to clinic blood pressure. And it was also subsequently shown that ambulatory blood pressure was a better predictor of target organ damage than clinic or office blood pressure. This is a topic that I'm certain will be discussed further by the next speaker. But as a result, the spectrum of hypertension based on the difference of measurement in the clinic and outside of clinic is not always clear-cut. It's not always black and white. On the contrary, actually, because the spectrum had several shades of gray. Since we could define hypertension independently by each of the two methods, which is the out-of-office blood pressure and the office or clinic blood pressure, together we will yield the following of 4 potential group of patients. The first one is those normotensive by both methods. This is the group that we call true normotensive. And the second group are those who are hypertensive by both methods. It's either the out-of-office blood pressure measurement or the clinic blood pressure. And this group, the second group, we name or we call sustained hypertension. And the third group is those who are hypertensive by clinic measurement and normotensive by ambulatory or home measurement, the group which we call white coat hypertensive. And the fourth are those normotensive by clinic measurement and hypertensive by ambulatory or home measurement. And this is the group that we label mask hypertension. And from a clinical point of view, the first two groups, the true normotension and the sustained hypertension, are relatively easy to deal with since both methods give the same classification. I think of more interest are the groups for which there are these disagreements, the white coat hypertension and mask hypertension. Now, the prevalence is known to vary depending on the cutoff used and the measurement methods, but the general rule of thumb is the white coat hypertension consists of 20% of all hypertensive population, but could be as prevalent as 50% in certain group like the elderly. While masked hypertension is said to be present in around 10% of general population, potentially could be higher in high-risk groups like diabetes or chronic kidney disease. And we'll start by reviewing each group separately. And first one is the white coat hypertension. And by definition, white coat hypertension refers to the untreated condition in which blood pressure is elevated in the office, but is normal when measured by ambulatory blood pressure or home blood pressure or both. The American guidelines, as Dr. Lourdes already pointed out, they used 130 by 80 millimeter mercury cutoff for clinic blood pressure for the classification or definition of hypertension. And then for the white coat hypertension, thus the clinic blood pressure should be over 130 over 80, but the daytime or daytime ambulatory blood pressure or home ambulatory blood pressure should be lower than 130 over 80. And the European guideline, and may I say the rest of the world, uses a cutoff of 140 over 90 in clinic and either 130 over 80 for 24-hour or 135 over 85 for daytime or home blood pressure. The etiology of white coat hypertension is kind of poorly understood, but it's contributed to psychological factors like stress or anxiety, and also the sympathetic and endocrine systems have been implicated in this condition. We have to suspect the presence of white coat hypertension when we encounter stage 1 office or clinic BP hypertension, and we also could see high variability of office and clinic blood pressure from visit to visit, or severely elevated office or clinic blood pressure without signs of target organ damage. The significance of white coat hypertension in the development of cardiovascular disease is somewhat debatable. There are some evidence of increased risk of transitioning to sustained hypertension compared to normotensive. The data from Pamela study population concluded that when individuals with true normotension, white coat hypertension, and mask hypertension are re-evaluated in 10 years The white coat hypertensive had the risk of transitioning to sustained hypertension over twofold compared to the true normotensive. Thus, it could be argued that white coat hypertension could be or should be classified as a pre-hypertensive state, as individuals with white coat hypertension have increased risk of developing sustained hypertension when compared with a truly normotensive population. And the target organ damage, several indices to describe target organ damage in relation to hypertension are left ventricular hypertrophy or carotid intermedial thickness, and both of these variables quite consistently showed significant difference between true normotensive and white coat hypertension, although white coat hypertension still showing lower or better values than the true hypertensive. And but how this translate into heart outcome of adverse cardiovascular events or cardiovascular deaths are still inconclusive. Some meta-analysis concluded significant higher rates of cardiovascular disease in white coat hypertension compared to normotensive, but results are not uniform, and some might argue that the difference in defining the white coat hypertension definition is sometimes different in different studies, and this might contribute to discrepancies in the result. And with that in mind, we come to the most interesting question: do we need to treat white coat hypertension? As of currently, there is scarcity of good quality randomized clinical trial data on antihypertensive treatment of white coat hypertension. The systolic hypertension in Europe trial and the hypertension in the very elderly study showed some evidence that treating white coat hypertension in over the age of 60s in the cis-tier and over 80s in the high-fat might confer some protection to future cardiovascular events, but these are both post hoc analysis and needed to be interpreted with cautions. Currently, I think if we take the risk versus benefit approach, seems like most agree that white coat hypertension may be no need to rush for treatment, because of course we see the risk of too aggressive treatment, potential hypertension, and of course other drug-related side effects. But the benefits is uncertain. We are not entirely certain how white coat hypertension translate into cardiovascular outcome. And there are robust evidence that office blood pressure is a less reliable predictor than out-of-office blood pressure, which means that most likely this is a borderline benign condition. And also white coat hypertension is more common in mild hypertensive stage 1 hypertension, who are likely to have a lower overall cardiovascular risk. And I think right now the emphasis should be made in efforts to accurate assessment of overall cardiovascular risk, especially to detect the presence of hypertension-mediated organ damage, and of course a regular monitoring of blood pressure and also the cardiovascular risk. And the European Society of European Society of Cardiology and European Society of Hypertension guideline for the management of hypertension in 2018 recommend that the first line of advice for white coat hypertension is lifestyle changes. The lifestyle changes aim at reducing cardiovascular risk, as well as regular follow-up with periodic out-of-office blood pressure monitoring. So lifestyle changes and regular follow-up just to see the trend of the blood pressure in a certain patient. When do we consider giving drug in white coat hypertension? The European Society recommend that the drug treatment may be considered in people with evidence of hypertension-mediated organ damage, or in whom cardiovascular risk is high or very high. But this is, as you can see, a class 2B recommendation, and the level of evidence is not so good. It's just a C level of recommendation. And routine drug treatment for white coat hypertension is currently not indicated. And we move on to the next group, which is the masked hypertension. Masked hypertension, of course, is the opposite of white coat hypertension. It is defined as the blood pressure that is normal at a physician's office, but higher in other out-of-office settings. Thomas Pickering was the first to use the term masked hypertension to describe this entity, which was previously known as reverse white coat hypertension. And the pathomechanism for this condition falls into one of the two categories. The first one is the low office blood pressure occurred relative to ambulatory blood pressure. It could occur when the stress or anxiety of a patient is lower in a doctor's office, and also we could observe this in postprandial blood pressure reduction in the elderly. And the second is this, it could be that the higher ambulatory BP is selectively occurred due to lifestyle factors such as smoking, physical inactivity, mental anxiety, job stress, and sedentary individuals with low exercise tolerance in daily activities, but in the physician office when he or she is resting, the basal blood pressure could be lower than the casual blood pressure could be lower than the usual or basal blood pressure at home. And when to suspect masked hypertension, the first one, of course, a normal clinic blood pressure with signs of target organ damage and the presence of other cardiovascular risk factors, such as diabetes, obesity, and excessive alcohol intake and smoking. And masked hypertension had a very significant role in the transition to sustained hypertension compared to normotensive, and also consistently showing worse target organ damage compared with normotensive. And there was also good evidence supporting an association to increased cardiovascular disease and stroke. So do we need to treat masked hypertension? Considering that the well-documented increase in cardiovascular risk in this group of patients, it provides a good rationale for the treatments because masked hypertension is not considered a benign entity. And out-of-office blood pressure measurement generally provides better cardiovascular risk stratification than office BP. And several studies, I quote here the Japan Morning Search and Japan Morning Search Target Organ Protection studies, showed that treatment of masked hypertension with intensive antihypertensive therapy targeting morning home BP was associated with decreased target organ damage in 6 months. Of course, this was retrospective analysis, and there is the anti-mask, the antihypertensive treatment in masked hypertension. This is an RCT, but it has small sample size and a high dropout rate, but it showed a marked improvement rate of target organ damage in the treatment group. And during pharmacological therapy, of course, regular monitoring should be performed with out-of-office blood pressure measurement and not clinic blood pressure to ensure that masked uncontrolled hypertension does not occur. And the European Society Guideline for the Management of Arterial Hypertension, similar with the white coat hypertension, the first line of advice should be lifestyle changes and followed, of course, by regular follow-up. And antihypertensive drug treatment should be considered in masked hypertension to normalize the out-of-office blood pressure. And this is a 2A recommendation. And the antihypertensive drug up titration should be considered in treated patient whose out-of-office BP is not controlled, or the masked uncontrolled hypertension because of the high severe risk of these patients. And maybe I just skip this part due to constraint of time. And we move on to the last two groups of today's topic. The first one is sustained hypertension, which is defined as the true hypertension when blood pressure is elevated both in clinic or office setting and out of office blood pressure measurement. And the last one is resistant hypertension, which is defined as uncontrolled sustained hypertension despite the use of 3 antihypertensive drugs of different classes. Sorry. I think the emphasis for today's discussion for sustained hypertension should be diagnosis confirmation. As we have discussed previously, disagreement between office blood pressure and out of office blood pressure could be problematic at times. It is important to confirm the presence of sustained hypertension. The European guideline recommended several ways to do this. The first one is to take average from multiple clinic BP measurements, at least 3 readings from 2 separate occasions, or to truly eliminate white coat hypertension or mask hypertension, to perform out-of-office blood pressure measurement either by ambulatory or home blood pressure, provided that these measurements are logistically and economically feasible. And when the diagnosis of sustained hypertension is confirmed, treatment should be given based on risk stratification. And the broad agreement that Dr. Lourdes already also mentioned, that the basis for therapy currently is start with combination therapy, single pill preferred, and the backbone of therapy is either an ARB or ACE inhibitor, a CCB, and or a thiazide or thiazide-like diuretics. And the last group is resistant hypertension. Resistant hypertension is defined as uncontrolled blood pressure despite the use of 3 or more antihypertensive agents of different classes, including a diuretic, usually thiazide-like, long-acting calcium channel blockers, and RAS blocker, either an ACE inhibitor or ARBs, given at maximal or maximally tolerated dose. And there's also one terminology that is sometimes got confused over whether it's resistant or refractory hypertension. Refractory hypertension nowadays is defined as uncontrolled blood pressure despite the use of 5 or more antihypertensive agents of different classes, including a long-acting thiazide-like diuretics and a mineralocorticoid receptor antagonist. The diagnosis of resistant hypertension is not easy. It requires exclusion of pseudo-resistance, whether it's improper blood pressure measurement technique or white coat effect, and also exclusion of undertreatment or clinical inertia, medication non-adherence, or secondary hypertension. The pathophysiology for resistant hypertension, it's mostly said to be fluid retention mediated by aldosterone excess. And that's why in most classification or definition of resistant hypertension, it includes the point that one of the drugs given is a diuretics or thiazide-like diuretics. And that is why the mineralocorticoid receptor antagonist should be included in the pathway of treatment for resistant hypertension. And the significance in cardiovascular disease, I think it is undebatable that it signifies a high-risk phenotype of hypertension. And this is the American Heart Association scientific statement for evaluation of resistant hypertension. The first step, of course, to confirm treatment resistance, because since this is the American guideline, they're using cutoff of 130/80, but we could always use the 140/90 cutoff. And patient taking 3 or more antihypertensive agent, including a long-acting calcium channel blocker, a RAS blocker, and a diuretic at maximal or maximally tolerated dose. And to exclude pseudo-resistance, first to confirm adherence to antihypertensive therapy, and to perform 24-hour ambulatory blood pressure monitoring. If it is unavailable, use home blood pressure to exclude white coat effect. And of course, always to assess for secondary hypertension, and also to assess for target organ damage. And the management, after we exclude other causes of resistant hypertension, is the first one, course, always lifestyle modification, ensure a low sodium diet, and maximize lifestyle intervention like uninterrupted sleep, overall dietary pattern, weight loss and exercise, and optimize the 3 drug regimen, ensuring adherence, and diuretic type must be appropriate for kidney function. Step 2 is substitute optimally dose thiazide-like diuretic or chlorthalidone or indapamide for the prior diuretic. We usually give hydrochlorothiazide for first line, but we encounter resistant hypertension, we might consider substituting it into chlorthalidone or indapamide. And step 3 is to add mineralocorticoid receptor antagonist, spironolactone or alprazolam. In Indonesia, we already have spironolactone. And if BP is still not at target, we could add beta blockers if there are, of course, no contraindication for this. If beta blocker is contraindicated, consider central alpha agonist. And if these are not tolerated, consider once daily diltiazem. BP still not at target. Step 5 is to add hydralazine. Hydralazine is a rather difficult drug to get here in Indonesia, but it is quite effective vasodilator, but the downside, it had to be given 3 times daily and titrate upward to maximum dose. And patients with congestive heart failure with a reduced ejection fraction, hydralazine should be administered on the background of a nitrate as a phenodilator to balance the arteriodilator effect of hydralazine. And if BP is still not at target, we could try to substitute hydralazine for minoxidil. And still not at target, there are some choices on device-based therapy like renal denervation and carotid baroreceptor activation, which I'm also certain would be discussed further by the next presenters. And to sum up, the white coat hypertension, isolated white coat hypertension is relatively benign, but might indicate high risk for sustained hypertension. Lifestyle modification is sufficient in most cases, but consider medical therapy in high cardiovascular risk and the evidence of target organ damage. Masked hypertension is not a benign condition as opposed to the white coat hypertension, and it is consistently linked to a target organ damage and cardiovascular events. And lifestyle modification and antihypertensive drugs are justified in masked hypertension, and long-term monitoring with out-of-office blood pressure measurement is also advocated. As for the resistant hypertension, the diagnosis requires exclusion of white coat effect and assurance of medication adherence, and evaluation includes identification of lifestyle issues, detection of drug interference, and screening for secondary hypertension. And the sustained hypertension or the true hypertension, where there is elevated blood pressure both in clinic or office setting and out of office blood pressure measurement, the treatment plan requires diagnosis confirmation, assessment of overall cardiovascular risk, and lifestyle modification. And with that, I conclude my presentation. Thank you.
Thank you very much, Dr. Danny. We will now move on to our next lecture by Dr. Narita. So Dr. Narita, may I have the CD of Dr. Narita, please? So Dr. Narita is a cardiologist at the Jichi Medical University, the editorial board in hypertension research, the journal published by the JSH. From Japan. He will be talking about evidence-based comparison of clinic blood pressure, home BP versus ambulatory BP monitoring guided hypertension management in the prediction of cardiovascular health outcomes. Go ahead, Dr. Narita.
Yes, thank you. So Professor Santos, so I'm sharing my slides. Can you show my slide? Can you see my slide? Okay. So I'd like to talk about the evidence-based comparison of clinical blood pressure, home blood pressure versus ambulatory blood pressure monitoring guided hypertension management in prediction of cardiovascular health outcome. So this is my COI. So I will introduce our research group evidences and findings. So at first, occasionally, we experience cases where blood pressure management is very difficult. So this case is a muscular hypertension patient. So 55 years old males, who were untreated hypertension, visited a hospital due to abnormal electrocardiography and LVH pattern in health checkup. So his blood pressure in office was normal. So 128 and 67 millimeter mercury. But echocardiography showed a mild LVH. So I'll check his home blood pressure and ambulatory blood pressure profiles. So his home blood pressure was elevated. So morning home blood pressure was 144 and 87 millimeter mercury. And this figure shows the ambulatory blood pressure profile in this case. So average of 24 ABP was 130 and 75, but he had a morning surge and elevated the morning blood pressure levels. So this is the phenotype of vascular hypertension. Next, so case 2 is patients of nocturnal hypertension. So 74 years male with a poor controlled hypertension, despite the use of 3 classes of antihypertensive medications, which visited my hospital. So his office BP was elevated 152 and 92 millimeter mercury. And OSAS was suspected by his sleeping snoring. And I checked his polysomnography. And polysomnography showed AHI more than 20 and diagnosed him with OSAS. So his ambulatory blood pressure profile is shown in this figure. So ambulatory blood pressure in this case was a mean of 24-hour blood pressure levels is 139 and 88. And morning surge was 28. So his nighttime blood pressure was elevated, so as 140 and 87 millimeter mercury. And also his morning home blood pressure was elevated, 150 and 94 millimeter mercury. This is nocturnal hypertension and resistant hypertension with OSAS. So next case is a patient with polyvascular disease, 70 years male. So he had a complication, many complications, and a prehistory of lead, such as ASO and multiple vessel disease in coronary artery and unilateral renal artery stenosis and carotid artery stenosis. He has a polyvascular disease. And clinic office blood pressure was elevated at 156 and 67 millimeter mercury. So in this case, in such a case, we physicians hesitate to add antihypertensive medications or tapering or antihypertensive medications. So this is a narrow therapeutic windows. So in this case, clinic blood pressure and office blood pressure is not enough to assess optimal blood pressure level in the patient, such as a complicated case. So out of office blood pressure should be considered in the management of hypertension. So in this case, repeated blood pressure measurement is needed. So that is a home blood pressure monitoring. And moreover, so in this case, nocturnal hypertension is suspected due to multiple complication and much risk factors. So ABPM should be considered in such a case. So in the management of hypertension, recommendation of out of office blood pressure measurements, such as home blood pressure and ambulatory blood pressure. So we physicians should consider out of office blood pressure measurement at first. And second, so importance of nighttime blood pressure measurement. And in the case of registered hypertension, so we physicians should home blood pressure and ambulatory blood pressure to assess daytime and nighttime blood pressure. So, and in complicated hypertensive patients, such a tight range of treatment target. So in clinical practice, so patients with progressive arteriosclerosis, for example, bilateral carotid artery sclerosis or chronic kidney disease, will be treated optimal blood pressure level that is not too high or low. So my agenda is shown on this slide. I like to talk about the usefulness of home blood pressure and blood pressure monitorings in clinical practice. So at first, so clinical blood pressure versus out-of-office blood pressure, such as home blood pressure and ambulatory blood pressure. So the evidences are established for the superiority of out-of-office blood pressure, so home blood pressure and ambulatory blood pressure, for risk stratification of cardiovascular events. So as shown this figure, so in this slide, so blood pressure measurements are usually affected by some bias or several environmental factors. But so the evidence is established in the out-of-office blood pressure, and international guidelines recommend out-of-office blood pressure in the diagnosis and management of hypertension. But so few studies have reported the comparison between home and blood pressure for the usefulness in the management of hypertension. This is such a guideline gaps in clinical practice. So next, so I'd like to talk about the comparison between home blood pressure monitoring and ABPM for cardiovascular outcomes. So there is no recommendation and statement for comparison between home and blood pressure in the international guidelines. So the available evidences about this issue is limited. There is a few studies to assess these issues. So we address them, this issue. So we assessed the data set of our prospective observational cohorts about the home blood pressure, the JHOP study. So in the JHOP study, so optional examination adding ABPM to home blood pressure was conducted in a part of participants who accepted the conducting ABPM. In the present analysis, so we assessed the prognostic power of home blood pressure and ambulatory blood pressure in a part of JHOP participants who were conducted both home blood pressure and ABPM. Number of participants was 1336 at median follow-up 7 years. So this slide shows the result of our study. So in the adjusted model, including patient factor and other and office blood pressure levels. So home blood pressure and 24-hour ambulatory pressure was significantly associated with cardiovascular risks. But so in the adjusted model, including both home blood pressure and ambulatory blood pressure, so home blood pressure levels was significantly associated with cardiovascular risks. But in this model, so 24-hour ambulatory blood pressure was not significantly associated with cardiovascular risks. And then, so in the analysis of the changes in goodness of fit by adding home and ambulatory blood pressure, so home systolic blood pressure was significantly improved the model fitness for cardiovascular outcomes. So from these findings, we demonstrated that we concluded that so home blood pressure was modestly superior to ABPM in predicting cardiovascular outcomes. And so third, so approach to nocturnal hypertension. So in Spanish data about ABPM, so a very large populations, 59, about 60,000 participants. So in ABPM cohorts. So in the adjusted model, including both nighttime blood pressure levels and daytime blood pressure levels. So nighttime blood pressure showed a linear relationship with cardiovascular prognosis. So they concluded that nighttime blood pressure is superior predictor for cardiovascular prognosis compared to office-based blood pressure and daytime ambulatory blood pressure. And then, so our research group have conducted nationwide cohort regarding ABPM, the JUMP study. So JUMP study is recruited about 6,000 patients and followed up mean 4.5 years. So nocturnal dipping pattern, so abnormal pattern such as non-dipper and riser is associated with cardiovascular disease, despite well-controlled 24-hour blood pressure levels. So this relationship was shown for total cardiovascular disease and especially in heart failure outcomes. So recent guidelines, so European Society of Hypertension 2023. So nighttime blood pressure is reported to be a superior predictor for cardiovascular outcomes compared to office blood pressure and daytime blood pressure. And the importance of nocturnal blood pressure has been highlighted in the latest European Society of Hypertension guideline ESH 2023. So I'll introduce our research group studied findings. So we concluded the J-HOPE nocturnal blood pressure study. So the J-HOPE nocturnal blood pressure study is using a home blood pressure device, can measure at night time. So 3 nighttime blood pressure measurements as an automatic oscillometric settings. So at AM 2 and 3 and 4. So masked nocturnal hypertension, so such as well-controlled daytime blood pressure. So daytime blood pressure is a daytime home blood pressure. So is a average of morning and evening home blood pressure levels. But so nighttime home blood pressure is elevated. So we call this phenotypes is as a masked nocturnal hypertension. So masked nocturnal hypertension evaluated by home blood pressure device has been assessed has been shown higher cardiovascular risks compared to well-controlled both nighttime and daytime home blood pressure levels. So we physicians should consider the assessment of nighttime home blood pressure despite usual daytime home blood pressure level is well controlled. In the next slide shows the nocturnal hypertension and the cardiovascular outcomes in resistant hypertension. So nocturnal hypertension is associated with cardiovascular outcome and a superior predictor compared to daytime home blood pressure, even in patients with resistant hypertension. So from these findings, so we physicians should consider also consider the nighttime home blood pressure also in resistant hypertension patients. And we developed a predictive score for nocturnal hypertension. So the risk factor for nocturnal hypertension was male and obesity and albuminuria and diabetes. In patients with these risk factors, so assessment of nighttime blood pressure should be considered. Then, next, fourth, usefulness of home blood pressure and ambulatory blood pressure in patients with resistant hypertension. So, our research groups conducted a JUMP study about ABPM and prognostic power of ABPM for cardiovascular disease. So, true resistant hypertension defined by ABPM has higher cardiovascular risks compared to well-controlled non-resistant hypertension. So in the risk stratification in this resistant hypertension, so out of office blood pressure such as ABPM should be considered to diagnose true resistant hypertension. The next slides also showed the importance of out of office blood pressure, home blood pressure in resistant hypertension. So true resistant hypertension defined by home blood pressure is also associated with higher cardiovascular disease risks compared to the group of well-controlled blood pressure. And moreover, so uncontrolled home blood pressure was associated with cardiovascular risks in patients with uncontrolled apparent resistant hypertension. So apparent resistant hypertension is defined as only office blood pressure measurement. So we should add the home blood pressure measurement to office blood pressure in this resistant hypertension patients. In these resistant hypertension patients. So the final section is in case of tight range of blood pressure target, so home blood pressure and seasonal variations. So intensive blood pressure control has benefits to prevent cardiovascular disease. So many evidences from intervention trials. So in 2015, so sprint trials, and in 2021, so step trials. So this interventional study established the evidences about intensive blood pressure control of intensive blood pressure control's benefit to prevent cardiovascular disease. But so in some cases, so we physicians hesitate to other antihypertensive medications for treatment treatment goal of these intensive blood pressure levels. So caution against intensive blood pressure management from Japanese guideline JSH 2019. So adverse events due to excessive antihypertensive treatment are concerned when aiming for tight antihypertensive controls. Particular attention should be paid to elderly patients. And on the other hand, and with regard to stroke, so there are warnings against excessive hypertension in bilateral carotid artery stenosis or occlusion of the main cerebral artery. And high-risk patients should be actively screened with carotid echocardiography and carotid vascular echo should be considered. So in hypertensive patients with a narrow therapeutic window, so seasonal variation should be taken into account to avoid excessive hypertension in summer and acute increase in winter. So in summer, so there's a elevated risk for excessive decrease hypertension, excessive decrease of blood pressure, and in winter, the risk for acute increased blood pressure is elevated. So this slide shows our research group's study findings. So in the JHOPE study, so regarding the home blood pressure cohort, so home blood pressure levels in winter is strongly associated with cardiovascular disease risks compared to home blood pressure levels in other seasons. And day-by-day blood pressure variability, this is evaluated by home blood pressure monitoring, is elevated. It's shown as a higher cardiovascular disease risks in winter compared to day-by-day blood pressure variability evaluated in other seasons. So blood pressure levels and variability in winter are more strongly associated with cardiovascular event risk than that in other seasons. So optimal blood pressure management is important, especially in winter. And in the post-hoc analysis of the interventional study for intensive blood pressure management using home blood pressure, the homed blood pressure study from Japanese groups. So increased risk of cardiovascular events has been reported in patients with a large elevate of blood pressure from summer to winter. And usefulness of early tapering such as before beginning of summer, and titration, such as before beginning of cold season of antihypertensive medications, has also been shown to be useful for reducing the seasonal variations, and it may have a benefit for prevention of cardiovascular events. So in summary, so for a 24-hour perfect control of blood pressure using home blood pressure monitoring and ABPM. So we should monitor the home blood pressure at first. And next steps, so nocturnal hypertension is residual risks. So we should consider ABPM or home blood pressure device can measure nighttime blood pressure to assess nighttime blood pressure levels. And in perspectives, so we scientists should try to approach blood pressure variabilities. This slide shows our research group's concepts for new approaches and individualized optimal therapy focused on home blood pressure, adding IBPM and novel devices. So home blood pressure centered and individual optimal therapy is required to achieve 24-hour blood pressure, 24-hour blood pressure perfect control. So this slide is a final slide of my presentation. Thank you for your attention. Okay.
Thank you very much, Dr. Narita. And we will now, again, because I'm the first chairman and Dr. Narita will be taking over the next session, we will have our Q&A. If I could call Dr. Danny, Siska back on so that we can just have a couple of questions. I don't particularly see any pending questions in the chat box. So if I may start off, very compelling evidence, great lectures from both. The ESC, the European recommendations, did give a lower cutoff for blood pressure targets, where we saw in international guidelines that they said that too aggressive BP lowering is significant. And we appreciate you bringing out, Dr. Narita, that in the 2019 Japanese hypertension recommendations, too aggressive is not encouraged because in particular individuals, of course, if the blood pressure is too low, we know that there can be a compromise in diastole and CAD patients. So if I may throw that first question, Dr. Danny, if we can just see what is the recommendation in Indonesia, in Jakarta with your guidelines, are you also giving a range for blood pressure targets where, although we know that we need 140/90 as the cutoff, is there a lower limit that you are discouraging physicians to be able to target among patients in Indonesia?
Yes, thank you, Dr. Lourdes. I think in Indonesia, currently, we adapt much of the International Society of Hypertension guideline because the concept of the optimal and essential is very applicable in our setting. Yes, I think most Southeast Asia region would agree on this. So yes, again, according to the International Society of Hypertension guideline, we're not very strict about the lower the better, and we're quite, I would say, rather As long as usually it's below 140 or 90, we're quite happy about that. But of course, as Dr. Narita and Dr. Lourdes mentioned, lower is not always the better, and the target for blood pressure should be made based on each individual risk factors. And it could vary from patient to patient according to age, of course, the hypertensive risk, the other risk factors present. I think usually in Indonesia we adapt the European and the International Society of Hypertension. The American guideline does not quite sit agreeably with
130
us,
over 80.
in terms of applicability.
Thank you for that. And may I try to understand too, in the European recommendations, they do include the 24-hour ABPM as the way to be able to diagnose hypertension, knowing that in Europe, it's actually covered. So in Jakarta, is a 24-hour ABPM covered by the government to be able to diagnose hypertensives in Jakarta? Is that something that the government supports?
Yes, and the universal coverage for the hypertension diagnosis cover the ambulatory blood pressure monitoring, but the problem is the availability. It's not widely available. Only on certain cities, on large cities, it is available in government hospitals. Otherwise, it's in the private sectors, and of course, the payment scheme for that is out of pocket.
Thank you. Thank you so much. Dr. Narita, if I can move on to you. Again, beautiful studies. May I know if the seasonal with that study showing that in winter versus, again, I think the difference basically is in the Philippines, we don't particularly have the 4 seasons. We only have rainy and we have hot and humid. So because of it, we don't particularly have these seasons. But very interesting. Was there a variability in, that early morning rise where blood pressure increases with that adrenaline surge, where we know that this is associated with most cardiovascular disease events from about 6 a.m. to 10 a.m. Was there an exaggeration of this early morning surge seasonally? I mean, more during winter than during the hotter months?
Thank you for your question. It's a very good point. So, as Dr. Santos mentioned, so the cardiovascular disease increase at the morning, especially in winter, and so we physicians often experience the patients who said, so my blood pressure is naturally elevated in winter, but lower in summer. So then I do not need antihypertensive medications. So
during the summer,
some patients say that. So our studies findings reported that blood pressure levels in winter is very important because it is associated with cardiovascular disease risks. So in my practice, so I I will check blood pressure levels in winter in patients. So if the patient's blood pressure levels increased only in winter, but not in summer, so I try to add antihypertensive medications especially in winter, and tapering in summer. So this is my personally clinical practice. So.
Oh, that's amazing. Again, because when we know that there are seasonal variabilities, absolutely. I mean, it means that maybe closer follow-up with our patients, just so the fluctuations in BP that doesn't translate can be a modifiable risk factor during these particular times. And again, because both of you discussed 24-hour blood pressure, the HYGEIA trial came out that showed that there was a recommendation maybe to be able to adjust medications to give antihypertensive therapy at night. What are your thoughts on chronotropism and giving particular medications at night?
Thank you. So this is a very important point. So at recent evidences, so a time study from UK, so that reported the bedtime dosing has
Correct.
not benefit to prevent cardiovascular disease. So recent European guidelines recommend not morning or bedtime
Right.
dosing.
Single pill.
So yeah, and
Yes.
so a part
Longer.
of experts mentioned that morning home blood pressure morning dosing is superior to compliance of taking antihypertensive medications compared to bedtime dosing. So this is a very difficult questions. So and Asia study is so so there's a questionable data
Yes, absolutely.
yeah,
And
yeah.
how they chose the medications because there was so much variability in the types of medications.
Yeah.
So again, I think basically from the two lectures that you guys gave, it's really giving that 24-hour blood pressure control. And we know that again, by guidelines recommendations, if you choose a single pill combination, that is a long-acting drug.
Yeah.
Again, both the morning surge, the nocturnal dipping will get impacted by one single combination. And that's the reason why when you block several pathways at the same time, really with single pill combination therapies, you get to better BP goals earlier. And at the same time, you give that full 24-hour control. There's a question here on the chat box I'm going to throw because we have a few minutes. So what exactly is the time for home BP measurement to disclose masked hypertension or nocturnal hypertension? Maybe I'll throw that to both of you because Dr. Danny spoke about masked hypertension and you with nocturnal hypertension. Go ahead. The time, sorry, I'll repeat. What exactly is the time for home BP measurement to disclose masked hypertension or nocturnal hypertension? So I guess basically it's asking the question, what to be able to say that this patient has masked hypertension, what is the time frame within which you'd consider that your patient has masked hypertension or nocturnal hypertension? Using, again, I guess the 24-hour ABPM, what the cutoffs are?
Okay, I think maybe I start first, or Dr. Narita would like to start. All right. If I understood correctly, the question is about home blood pressure monitoring or ambulatory blood pressure monitoring.
So home BP measurement.
Home blood pressure.
To disclose mask.
Oh yes, home BP measurement would have limitation to diagnose nocturnal hypertension. Ambulatory blood pressure monitoring is much more suitable to diagnose this. But as for the home blood pressure measurement for the masked hypertension, I think it follows the general rule for the home blood pressure monitoring recommendation, which is to monitor twice daily at morning after waking up, but not yet going into activities. And the second is at night after preparing to go to sleep and ready to rest for the day and take time to measure your blood pressure. Each measurement, either morning or night, we should perform 3 measurements. Usually I say 3 measurements. The first one eliminated, the second and third one, we average the values. And these are perform about 5 to 7 days in a row prior to our clinical visits, and the average of those values is what I usually consider the average home blood pressure monitor. And if those values are higher than the clinic or office blood pressure, then we could safely diagnose masked hypertension. If we think that there might be some doubt, we could of course send the patient for further assessment with ambulatory blood pressure measurement.
Great, thank you. And again, I agree. The limitation to home BP measurement is really the fact that you cannot measure nocturnal hypertension, which really gives us the basis for pushing for ABPM, because then they reveal blood pressure readings at night. Any thoughts, Dr. Narita?
Thank you for your questions. I personally think morning blood pressure is a superior predictor to detect nocturnal hypertension. So from our research group study findings, morning home blood pressure is strongly associated with nocturnal hypertension compared to evening home blood pressure levels. So from these findings, I recommend morning home blood pressure compared to evening home blood pressure. I personally think.
Thank you. And again, these are compelling evidence. We've discussed much today, particularly talking about masked hypertension, white coat hypertension, nocturnal hypertension, seasonal hypertension. And beautifully, again, learning these allows us to change guidelines with an impact for how we treat our patients in the Asia Pacific region. So it has been an encouraging Q&A. Without further ado, Dr. Narita is now chair of the second part of this session, where he will be introducing the lecture for the next two speakers and the Q&A after. Thank you.
Yeah. Thank you, thank you, Professor Santos. So I will move to next lecture. So Dr. Professor Pan, cardiologist at National Taiwan University Hospitals. So he gave us about lecture about salt-sensitive hypertension as a unique entity in hypertension management. So Dr. Pan, can you give your lecture?
Sure. Thank you, Dr. Narita, for introduction. I will share my slide right now. Okay, so can everybody see my slides right now? Okay. Okay, so it is an honor to be here and to share about my opinion about self-sensitive hypertension, which is a unique entity in our treatment daily practice of hypertension management. This is my disclosure. Self-sensitive hypertension is defined as a blood pressure change that changes parallel to the changes in daily salt intake, and it is considered as an important risk factor for cardiovascular mortality and morbidity, even considering about patients' baseline characteristics or baseline blood pressure level. And for the prevalence, there are around 30 to 50% of hypertensive patients are considered to be self-sensitive, and about 1/4 of normal-tensive patients are considered to be self-sensitive. And it varies between ethnic groups, and its heritability could be 74% in African descent, and also around 50% for Chinese or Asian patients. And it has a genetic and also the environmental factor background. And we will talk slightly about the genetic background later on, but about the environmental factors. There are metabolic factors such as insulin resistance and abdominal obesity to be associated with self-sensitivity. For example, for those, there are evidence showing that for those with metabolic syndrome, there are 71% of patients who had self-sensitive hypertension. And for those without metabolic syndrome, there is only 36% who had self-sensitive hypertension. And it is statistically significant. As I said, there is a genetic background, and there are variable genetic factors that may be associated with self-sensitive hypertension. To take as an example, we like to introduce the atrionatriuretic peptide, and impaired natriuretic peptide will result in a sodium retention and suboptimal vasodilatory response to daily dietary sodium loading. And as I said, metabolic syndrome is associated with a significant self-sensitive blood pressure, especially in East Asia, as seen in this study in 2009. if we consider a low sodium intervention as a daily intake of sodium chloride less than 3 gram per day, and a high sodium intervention of sodium chloride 18 grams per day. And we see that for those with metabolic syndrome, which is shown in red, there is a significant drop in systolic blood pressure of 8.8 millimercury. And for those without metabolic syndrome, there is only a 5.2 millimercury drop in systolic blood pressure. And as in during the high sodium intervention period, there is around 7 millimercury elevation in systolic blood pressure, and only 4.6 millimercury rise in sodium systolic blood pressure. So as we can see that if we define the high salt sensitivity as a change in mean blood pressure over 5 millimercury with either low or high sodium diet, then we can see that metabolic syndrome is truly associated with salt sensitivity in the study. And more interestingly, if we all know that metabolic syndrome is defined as an elevated blood pressure, impaired glucose tolerance, high triglyceride, low HDL, and abdominal obesity. And with more risk factors that is presented in the metabolic syndrome, we can also see that the prevalence of salt sensitivity also increased, which we see there is a graded relationship with an increase in risk factors. So in order to explain the involvement of metabolic syndrome with salt sensitive hypertension, the scheme is illustrated in the following figure. There are several parts. The one is the renin-angiotensin aldosterone system here. And we see that if the adipocytes or there is a metabolic derangement, there is an activation of renin-angiotensin aldosterone system, RAS, and resulting in increased sodium reabsorption and volume overload and vascular stiffening, and also the impaired. So there would be an impaired signaling of atrial natriuretic peptide that would cause impaired sodium potassium exchange, which would in turn cause increased sodium reabsorption, and a resultant is increased blood pressure elevation. So what is the measurement recommendation by AHA to define salt-sensitive hypertension? There are variable literatures which had described about how to measure salt-sensitive blood pressure. And the initial report was reported by Kawasaki and colleagues in 1978. Basically, the measurement of salt-sensitive blood pressure requires large changes in sodium and volume balance. And there would be inpatient protocol and outpatient protocol. For inpatient protocol, there would be a large amount of salt loading in the first day, and the second day would be sodium depletion, which includes very low sodium and furosemide to deplete the sodium. Sorry. And for outpatient protocol, it would include a daily intake of a high sodium diet, which contains more than at least more than 250 millimolars for a week, daily for a week, followed by an equal period 1 week of low sodium intake, which is less than 50 millimolar of sodium chloride in a week, every day. And the salt-sensitive blood pressure is assessed by the change in blood pressure from the end of the high salt period to the end of the low salt period. And the absolute the intake of the salt intake should be absolutely controlled by and carefully measured by 24-hour urine sodium excretion measurements. And the blood pressure measurement is suggested to be multiple times, and the measurement should be very careful to reduce the variability of BP measurement and to give a more accurate estimate of how the blood pressure changed during the salt intake. And so the measurement options should probably include multiple times of standardized clinic measurement or even ambulatory blood pressure monitoring. And this is the reference method proposed by Kurtz and colleagues in 2017. And the procedure should go by 1 week period of low salt intake, no more than 50 molars of sodium chloride per day, followed by 1 week period of high sodium intake of around 250 molars of sodium chloride per day. And there should be multiple measurement of 24-hour urine sodium excretion to confirm the patient's sodium intake. And the cutoff to classify normotensive patients as salt sensitive is to measure the mean pressure changes for more than 3 to 5 millimercury. And the cutoff value to classify hypertensive patients as salt sensitive would be mean pressure change from the beginning to the end. There is a change of 8 to 10 millimercury. And if we compare the inpatient and outpatient dietary protocol, we see that there is a very high reproducibility in the outpatient protocol. Okay, so in order to treat the cell-sensitive hypertension, we need to consider the main biological pathways involved. And that includes multiple pathways such as RAS system, the endothelin system, the nitric oxide system, the sympathetic tone system, the hyperinsulinemia system, and the natriuretic peptide. And for these pathways, we have briefly discussed before. And the underlying pathways I would discuss slightly in detail in this slide. For the RAS system, if the patient has cell-sensitive hypertension, the RAS system would be, the response of RAS system would be blunted. That is to say that if the patient had increased sodium load, normally the renin would be suppressed. And if the patient had low sodium load, the renin would be activated. But in patients with sensitive hypertension, this response would be blunted and resulting in abnormally activated RAS system. And also for endothelin and nitric oxide, I would discuss about the biological pathway in the next few slides. In the nitric oxide system would be inhibited, and or even the nitric oxide would be diverted to interact with an increased oxidative stress, and decreased available nitric oxide will result in impaired vessel relaxation. And also, the sympathetic nervous system is activated with increased sodium load. That is, the pathway is to be further elucidated in the few slides. And also for hyperinsulinemia, there would also, as I said, that it is this pathway is probably associated why metabolic syndrome is associated with cell-sensitive hypertension. And for the impaired natriuretic peptide pathway, as I said, if there is an impaired ANP pathway, this would result in sodium retention. And in 2018, there is a network meta-analysis comparing about the different efficacy of drugs or versus placebo or drugs versus drugs in salt-sensitive hypertension. And this network meta-analysis showed that among all kinds of antihypertensive medication, that is to say ACI, ARB, CCB, beta blockers, or even other medications such as clonidine or diuretics, the most effective intervention for cell-sensitive hypertension would be a calcium channel blocker plus thiazide diuretics. And that is for those patients without metabolic derangement such as obesity. And for those with concomitant obesity, calcium channel blockers and with the use of metformin could improve cell sensitivity and to reduce those the blood pressure among those patients. And more recently, we all know the advent and widespread use of ARNI among heart failure patients. And we are all aware of the dual mechanism as underlying the ARNI, the drug of ARNI. Basically, the dual mechanism includes the RAS system inhibition and the neprilysin inhibitor, which promotes the production and preservation of natriuretic peptide. And both pathways could induce vasodilatation, reduce sodium reabsorption, reduce fibrosis, reduce vessel hypertrophy or remodeling, and promotes vessel regeneration and protection. And this dual pathway includes ARB, which is valsartan, and also a neutralizing inhibitor, which is sacubitril. And this drug, ARNI, may not only protect heart failure patients, but may also regulate water and electrolyte balance by promoting natriuresis and blood pressure reduction, both beneficial for the treatment of self-sensitive hypertension. And the study on the natriuresis, diuresis, blood pressure, and NT-proBNP level by using the ARNI is actually studied in 2000 and published. The study is published in 2017. And this is a phase 2 randomized double-blind crossover multi-center study for treating patients with self-sensitive hypertension. And self-sensitive hypertension was diagnosed if the mean pressure increased by more than 10% when switching from a low sodium diet to a high sodium diet. And the low sodium diet was defined right here as less than 50 millimolars per day, and a high sodium diet defined as 320 millimolars per day. And each was administered for 7 days, as you can see in the middle part of the flowchart. And there is a crossover design in the ARNI and ARB valsartan. As you can see, between the two groups, there is a similar age, gender distribution. All of them are Asian, and most of them had overweight. The average body mass index is around 26, which is similar between two groups. And the BP parameters were also similar. All in all, 209 patients were enrolled, and only 74 patients met the criteria for self-sensitive hypertension. And 72 patients were randomized into either two groups. And as we can see from the result that the using ARNI further increased the urine sodium excretion with a significant level. And also the use of ARNI from the first day to the end of the month, there is a significant reduction in NT-proBNP. And also a more reduction compared to valsartan. And as for blood pressure, there is a significant drop in either systolic, diastolic, and mean blood pressure. And also there is a significant drop of nocturnal blood pressure compared with from ARNI compared with valsartan. And then also the new therapeutic target would be sodium channel, which is an epithelial sodium channel, ENaC. And there is a strong association between the ENaC and salt-sensitive hypertension. And it is studied as a multifactorial role in recent years. As we can see that there is the role of epithelial sodium channel, which is ENaC, as more as a sodium transporter and a sensor and transducer in organs more than other than kidneys. It exists in neurons and also in immune cells such as dendritic cells and also vascular smooth cells. And the ENaC would induce inflammatory cytokine release and vascular stiffening, as well as activation of sympathetic tone. So more work is considered to be necessary in order to develop associated ENaC inhibitors that selectively target the channel, especially in non-epithelial cells. So this is my take-home message. There is a rather high prevalence of self-sensitive hypertension. As we can see, there is around up to half of the hypertensive patients with self-sensitive blood pressure, and also around one quarter of a prevalence among normotensive patients. And as we can see that self-sensitive hypertension itself is a risk factor for cardiovascular mortality and morbidity. And those normotensive patients that had a self-sensitive status are prone to develop hypertension in the following years. And for for African descent, and especially in our case, East Asians are prone to develop cell-sensitive hypertension. And there are multiple pathways that are associated with this cell-sensitive hypertension, and among all, RAS, natriuretic peptide, and ENaC all play important roles. So targeting all these pathways could be promising and effective in treating cell-sensitive hypertension and to reduce nocturnal blood pressure, as we know as an important cardiovascular risk in hypertension management. Thank you for your attention.
Thank you, Dr. Pan, for your presentation. So I'll introduce next speaker. So Professor Wongpraparut. He's a director of cardiac catheter laboratory at the Faculty of Medicine, Sri Lai Hospital, Mahidol University, and vice president of Cardiovascular Intervention Association of Thailand. Professor Wongpraparut, please make your presentation.
Thank you very much, Professor Narita. Thanks for kind introduction. So let me start my slide. Are you able to see my slide? Good afternoon, everyone. It's my honor to be here to be part of the APSC Hypertension Summit webinar on this today. My role today will be talking about contemporary role of renal nerve innervation in management of hypertension with high cardiovascular risk. This is my disclosure. So I think we have been learned that hypertension is a significant risk for future cardiovascular event. In the younger patient, when they have hypertension, the higher the number, relative risk of all-cause mortality, cardiovascular event, coronary heart disease, and stroke was high. And this risk is also exponential. If you look in the younger patient, as I showed in the previous slide, when you have the older age, absolute risk of the coronary heart disease or stroke is even higher. And you also have other long-term effects like atrial fibrillation, valvular heart disease, fatigue syndrome, peripheral vascular disease, CKD, and erectile dysfunction. So not only hypertension itself is a cause of the future cardiovascular event, but I think in recent years as guideline, as Dr. Santos, Professor Santos have been shown that is also help for the risk prediction. So in this latest ESH guideline recommend, you not only grading of the hypertension to be optimal, high normal, grade 1, grade 2, and grade 3, but you also need to look at the patient parameter. If the patient have like hypertension related disease, diabetes, CKD, or established cardiovascular disease in CKD, this put them in very high risk. And this is the cardiovascular risk according to grade and state of hypertension. And you can see that if the patient have the similar blood pressure, but if they have the established or have the CKD or diabetes, they put them on very high risk compared to patient without any risk factor. So I think in the patient with high cardiovascular risk, hypertension is a cause and also as a set up for the predictor for the future cardiovascular event. And these need to be controlled. This slide I have been shown patient over close to like 1 million people, 300,000 people to 600,000 people. And you can see that even we can reduce blood pressure as low as 5 mmHg. We can reduce major cardiovascular death by 10%, stroke by 13%, heart failure by 14%, and cardiovascular death by 5%. But even we additional blood pressure reduction up to 10%, you can reduce major cardiovascular death by 20%, heart failure by 28%, and cardiovascular death by 13%. So controlling blood pressure is very important, especially in the high cardiovascular risk patient. But the problems are in the current practice, I think many patients still not able to get the blood pressure control, may have like resistant hypertension, have difficult for blood pressure control, even though put on many medication. So we need to look in the non-pharmacological aspect in this difficult control blood pressure, especially in the high cardiovascular risk. Sympathetic nerve have been correlated with hypertension. Sympathetic nerve also have the interact with blood pressure. So when you excite, when we have like stress, blood pressure will go up by increase of the renal pelvic pressure or renal ischemia. That will activate the afferent pathway to activate the central nervous system. And that will affect into the afferent pathway to increase renin, sodium reabsorption, and water resistance, and cause a high blood pressure. If this is occasionally, intermittently, this might not be a problem. But if the patient have chronic stimulation of this sympathetic nervous system, there will lead to uncaused effects like uncontrolled hypertension and also cardiovascular event later on. So renal nerve is one of the pathway that we can use a sympathetic catheter-based approach. We have many systems like ultrasound-based device, or we can use the catheter-based device like the frequency ablation to ablate the renal nerve. And then with this have been shown that have proof of concept that doing this, we can reduce central sympathetic nerve activity as measured by MSNA microneurography, that you can see from the study from Dr. Lourdes that after the nerve ablation, you have reduced sympathetic activity significantly from baseline to 12 months. And also another measurement from the norepinephrine spillover, you can also significant reduction norepinephrine spillover after renal nerve denervation. Hold on just a second. So we have many study have been done starting from sympathetic hypertension 1, hypertension 2, hypertension 3, simplicity hypertension Japan, and off-med and on-med, and global simplicity as a real-world clinical data. And you can see from this study, we have significant reduction of blood pressure compared to baseline as 20 millimeter mercury reduction in the simplicity 1 with prospective registry, and above 6-7 milliliter mercury reduction. Only a trial that is not success have been failed to show is simplicity hypertension 3 with the single blind randomized sham control, which is no significant reduction compared to the sham. So let me go step by step on this trial. So I think based on this simplicity hypertension 3, that randomized sham control proof of concept. So they have to repeat another study called spiral hypertension off-med. And this is multi-center international single-blind randomized sham control. Randomized 80 patients with the drug naive or drug discontinuation between RGN versus sham. Patient to be part of the trial have to be office blood pressure 150 to 180. Our mean ambulatory blood pressure is 140 to 170. And patient also, because we compare between the drug and device, So they have done the drug surveillance to ensure the patient compliance not taking any medication. We measure the change of ambulatory blood pressure at 24 hours at 3 months. And we can see here, this is proof of concept that compare between the sham and renal nerve denervation. You have significant reduction of blood pressures 4 millimmercury on ambulatory blood pressure and about 6.6 millimmercury of office systolic blood pressure. Another trial has been done on spiral hypertension on-met. This is include 20 patient aged 20 to 80s have mild to moderate hypertension, and they have the office blood pressures of 150 to 180, taking stable dose of 1 to 3 antihypertensive medication for last 6 weeks. Then the randomized again between RDN and sham. And then drug surveillance also done to make sure that they comply because we compare intervention with the device to medication. So there should not be any change of medication in the during the study period. They look at the blood pressure at 6 months, and we can see 24-hour systolic blood pressure was significant reduction, about minus 9 millimmercury, and also office systolic blood pressure also reduction. And these two trials have been proof of concept that renal nerve denervation is help in blood pressure control. As I mentioned, the previous trial of simplicity hypertension 3 have been randomized, and this one showed to be failed to demonstrate blood pressure reduction between RDN compared to control. And you can see because of the control at 6 months, they also have significant blood pressure reduction. But this trial also have been commented because maybe I have heterogeneous of patient, maybe operators might not be experienced enough. Also, there have been change of medication during the trial. So that may be caused to have the fail to RDN to be shown to be have benefit of blood pressure reduction. But recently at TCT last year, have been showed the data of the long-term outcome of catheter-based renal nerve denervation follow-up on the simplicity hypertension 3 trial. So these trials, as I have mentioned, this patient who have resistant hypertension with office blood pressure more than 160 or ambulatory blood pressure more than 135 on maximum rate of drug, compare between sham and RDN. And at 6 months, they failed to show the primary endpoint because of the sham also have significant reduction of blood pressure. So there's no difference between RDN and sham. But once they follow up for long term, up to 5 years, you can see the split have been difference between the RDN compared to sham. In the patient with RDN, you have about 13 millimmercury reduction. At 24 months, you have another 20 millimmercury reduction, and 36 months is 22 millimmercury reduction compared to sham, with only 5 millimmercury reduction. And once they see this data, patients have been allowed to cross over. And the rest of the patients who have been followed up for 5 years, you have average reduction of the minus 30 millimmercury reduction in the patient with RDN. And this was also have been changed in terms of the ambulatory blood pressures at 24 hours. You can see minus 7.5 up to 16 millimmercury reduction at 4 years. And it's not only reduced blood pressure, but it's have 24-hour blood pressure reduction. As Dr. Narita, Dr. Santos have been discussed about importance of the nocturnal hypertension, importance of the morning surge, especially in Asian people, that will be predictor of the MI stroke. And I think when you have this device that working all the times, you can see that the blood pressure reduction is always on effect. compared to control, which is no reduction. And when you look at the patient who have the optimal control, when you look at the RDN, you can see that at 6 months, this still significant patient have blood pressures over 160, but it's become less and less at 3 years. And when you compare to the sham, that is no patient have been controlled with initial, but once they've been allowed to cross over at 36 months, they have a significant proportion of the patient have much better blood pressure control. So let's look at the real world data. So we look at the randomized control trials. What about the real world data? So I think the global simplicity registry is prospective register 196 sites worldwide with the patient with hypertension receive RDN by local regulation. We have a patient over 2,000 patients have been followed at least up to 3 years. And you can see majority of the patients have the difficult blood pressure control with blood pressure is 160 over 90. And once they have the renal nerve denervation, they have significant blood pressure reduction at 12 millimercury at 6 months and about 16 millimercury at 3 years. And that also consistent with ambulatory blood pressure at 6 months and up to 3 years. This slide also have showed another important point with the safety. And you can see that the patient who have RDN in terms of the up to 3 years, there is no increased risk of cardiovascular death or any effect from the renal nerve denervation. So this procedure is very safe procedure. And we look, we're talking about the patient with high cardiovascular risk with disease burden and that have like a high risk. And you can see here up to 50% of the GSR-defined have the patient with high risk population. And you can see in this high risk population, there's significant blood pressure reduction across the board. Either patient have resistant diabetes, atrial fibrillation, CKD, isolated hypertension, elderly, pro-MI, pro-stroke, they all have significant reduction of blood pressure. The recent study on GSR sub-study also have been published. The blood pressure reduction compared to patient taking 0 to 3 medication, or the patient who have resistance with taking more than 4 medication. And you can see that on both group, there also significant reduction of blood pressure. So either you take a little bit blood pressure medication or take a lot of blood pressure medication, you have benefit from the RDN. They also have some other effect have been shown. This study just published in JAMA a couple of years ago. They look at the atrial fibrillation. When you treat atrial fibrillation with pulmonary vein isolation, compared to pulmonary vein isolation with renal nerve denervation to block sympathetic overtone. And you can see with additional pulmonary vein isolation with renal nerve denervation, you have significant reduce of recurrence of atrial fibrillation compared to doing a pulmonary vein isolation alone. So I think renal nerve denervation have true effect on the sympathetic activity, and that when you have sympathetic overactivity, lead to cause effect, not only hypertension, but also atrial fibrillation and other things. So I think this is can reduce as well. Recent from GSR have also looked in the risk reduction of the MACE over 3 years. And you can see compared to calculate cardiovascular event in the patient enrolled GSR with observed event was significantly lower in terms of MACE, cardiovascular mortality, and stroke. What happened in patient in the Southeast Asia, like in Thailand? So we have been did this RGN back in 2012, and we first initially published the data in 2014. looking a case series of 4 patients. You can see we treat of the patient with a high cardiovascular risk. One patient even had hemorrhagic stroke from hypertension at young age, taking almost like 7 or 8 medication. After RDN, you can see significant blood pressure reduction, but also more important, we have much blood pressure control. We also have recently published follow-up data on long-term outcome in hypertension research that Dr. Narita is editor about. We have been shown that in the Thai patient who underwent RDN during the period of 2012 and 2018, this is different catheter that have been used, and patients have been followed up to 9 years. And we use the effective of RDN by reduction of blood pressure more than 10 or reduce of blood pressure of both. And you can see here up to 9 years, once you did ablation, they also have always on effects, and effect have been last up to 9 years. There are some heterogeneous blood pressure response have been observed. You can see some patients, if I put like a forest plot graph here, some patients have even much blood pressure reduction, like minus 72 mercury reduction, but some patients also have increased. But obviously, hypertension is a mixed bag. So I think you have many causes to cause hypertension. But if you have patient with a neurogenic hypertension that we can predict like obesity hypertension, my essential hypertension, or have the high baseline ambulatory blood pressure. So I think that could be a predictor for the case. So I think RDN, I think the most difficult part is how to choose the right patient. For the guideline, I think we have a lot of evidence, and all the guidelines have been recommended. I will focus on the Asia Pacific and recent update on the research guideline. So led by Dr. Kario and our ADEC group, we have been published the recommendation for RDN. Obviously, in the patient who have resistant hypertension or have like some sympathetic hypertension, or like as we discussed in the beginning, we have like a difficult hypertension, like morning hypertension, nocturnal hypertension, that could be a candidate. We also recommend the uncontrolled hypertension who have the established atherosclerosis and heart failure as a candidate for renal nerve denervation. In the Thai guideline, we just recently published in last year, and we recommend renal nerve denervation in the as class 1 in the patient who have refractory hypertension and the maximum tolerated hypertensive agent. In the patient who have established cardiovascular disease or progressive target organ damage, that's a class 2A. Routine use is a class 3. And for the last slide, on the ESH guideline, recommend RDN is a treatment option. We have in the patient who have the good renal function and have the uncontrolled hypertension despite use of drug combination. And that's a class 2, or have the drug treatment with the serious side effect or poor quality of life. RDN can be considering in the patient with resistant hypertension who have GFR more than 40. And when doing RDN, I think you should have the shared decision making into your team and to the patient information. And RDN should also be performed with the experience center that guarantee the appropriate selection of the patient and also completeness of the innovation procedure. In conclusion, I have been presents the data of the use of RDN in the patient with a high cardiovascular risk. As mentioned, uncontrolled hypertension, increased cardiovascular event is also a predictor of the poor outcome. Only 5 mmHg reduction of blood pressure, you can significantly reduce cardiovascular event and cardiovascular death. And RDN have helped to prove blood pressure reduction and is always on effect. And we have been demonstrate efficacy and safety of RDN in global Simplicity registry, Simplicity Hypertension 3, and our Thailand database. And we have the guideline recommend at the end to help management in the patient who have uncontrolled blood pressure when you use pharmaceutical and still not control. I think thinking about these procedures, especially in the patient who have high cardiovascular risk, that will help the patient. Thank you very much.
Thank you, Professor Wongpraparut. And I also appreciate the publication of your group's beautiful study data for our Japanese Hypertension Society, the Journal of Hypertension Research. Thank you.
Okay.
So,
thank you.
so,
we appreciate to participate in that journal too. It's a great journal.
Thank you. And so we will move to the question part for Dr. Pan's presentation and Professor Wongpraparut's presentation. So can I ask you questions? So Dr. Pan?
Sure. Yeah.
So you showed the slides for ANI and its effects to the salt-sensitive hypertension. So how do you think about SGLT2 inhibitors? So of course, so this drug is not adapted for only hypertension, so to diabetes and heart failure patients. So how do you think about the effect of SGLT2 inhibitor for salt-sensitive hypertension?
Okay. Thank you, Dr. Narita, for your question. I think there is increasing evidence showing that SGLT2 inhibitor would be beneficial in treating heart failure patients. I think salt-sensitive hypertension, one part of salt-sensitive hypertension would be the vessel relaxation, and also for impaired natriuresis. So I think I will look forward to seeing that SGLT2 inhibitor maybe in the role of treating salt-sensitive hypertension, but currently I don't see any published evidence showing that the effect of SGLT2 inhibitor on salt-sensitive hypertension.
So I think so there's a very strong relationship between salt-sensitive hypertension and heart failure patients. So especially in HFpEF patients. So to HFpEF patients, so SGLT2 inhibitor is adapted in the management of heart failure. So in perspective, so SGLT2 inhibitors so can use for salt-sensitive hypertension. So with in patient with high risk for heart failure patients. How do you think? So do you have any comments on this issue?
Sorry, I don't quite get the question. Could you repeat your question?
I'm sorry. So I think so there is a very strong relationship between salt-sensitive hypertension and heart failure. So and SGLT2 inhibitors is now using for heart failure patients and HFpEF patients. So the guidelines, recent international guidelines recommend SGLT2 inhibitors for HFpEF patients. So in perspective, so how we can use SGLT2 inhibitors for salt-sensitive hypertension in patients with higher risk for heart failure patients. Do you have any comment?
Yeah, I think an important part of is a RAS system activation, and actually impaired inhibition of RAS system with high sodium load. So yeah, I think if there is solid evidence for SGLT2 inhibitor on treating heart failure patients, that the major part of mechanism behind heart failure is sodium and fluid retention and RAS system activation. Then sure, I think maybe SGLT2 inhibitor may also play a role in treating cell-sensitive hypertension.
Thank you. So, my country in Japan, we cardiologists can use ANI to a treatment of hypertension. So, but America, the United States and Europe cannot use for the hypertension. ANI cannot use ANI for the hypertension. So in Japan and China and Russia, so the physicians can use ANI for hypertension. So how do you think the effect of ANI for prevention of cardiovascular disease risks in only hypertensive patients?
Mm-hmm. Yeah, I think there's a major part that I think we all see from evidence that there is a high percentage of cell-sensitive hypertension among not only hypertensive patients but also normal tensive patients. So I think yeah, for certain high-risk patients, maybe we should be more aware of this sodium-sensitive trait, and maybe to early initiate drugs such as ARNI to treat the cell-sensitive status. Yes.
Thank you for your answer. So next, can I ask the question for Professor Wongpraparut?
Yeah. Sure.
So could you teach us the good responder for renal denervations, good response factors of renal denervations?
Thank you very much, Dr. Narita. I think that's a very important question. I think to select right patient is very important. We based on our experience, we observe that if the patient have neurogenic type hypertension, females, young females, or a little bit obesity, and have some obstructive sleep apnea, I think that we have great reduction of blood pressure. We even can take one patient off from our blood pressure medication from resistant, difficult to control, or we can better improve blood pressure control. They also have a lot of data because we block of sympathetic nerve activity. So the patient who have the sympathetic overtone, I think that will be predicted. But I think the problems in the real life is sympathetic activity is very difficult to measure because it's very dynamic all the time. But in the previous study, they looked for blood pressure variation as a predictor of the sympathetic overtone, heart rate variability, heart rate increase the baseline heart rate that have published in the European Heart. So you can put all this data. But but if you really don't care, I think when we put every patient, they always have a reduction. But if you want to get more, I think if you select this group of patients, they will have significant improvement of blood pressure. The guideline also recommend not to do in the patient with the poor kidney function. Patient have vascular complication like dissection, but we also have the case that patient have the difficult blood pressure, have abdominal aortic dissection, and we have to really, but they can control with the hypertension team. So we have to look at the CT and then try to get where to get the access. And once we get that renal nerve denervation, blood pressure much better control. So I think in the patient who have a little bit contraindicated, I think you have to really look and evaluate safety and risk and benefit of the patient.
Thank you. So thank you for your comments. And so many evidences for renal denervations published from Europe, Professor Bohum and Professor Mahfoud, so in their groups. So of course, the interventional trial is conducted in international studies. So in Asian patients, so what is important to recommendation of renal denervation. So do you have any comments on this issue?
So I think we lead by Dr. Kario, and we set up the group. Dr. T.D. Wang, also part of the group from Taiwan, and also we have the group representative from Southeast Asia. We recommend put in the ADEC, Asian Asia Press renal nerve denervation. So I think we also recommend that we see from our based on our Japanese Simplicity trial, we see the more blood pressure reduction actually in Asian compared to the European. I think they have some ethnic difference. I think when you have like people like African American in the based on the Simplicity country, they have response, but I think in Asian population we see a greater response. We also Dr. Kerr also have thinking as have been shown in your slide that morning surge, nocturnal hypertension. I think that predict of the future event. So I think if you can use single pill control, I think that will help. But if you try to use everything and you're still not able to control, I think that the group that obviously have some benefit. And obviously in our series, when the patient have refractory hypertension, you know that the outcome is not going to be good. If they come back and readmit with the heart failure, pulmonary edema, and I think life expectancies will be very short. But we have it show, we have like a very young patient. We have been treated for 10 years. At 10 years, they still response to treatment. They're still alive with without any cardiovascular complication. So I think this is the thing that I think you might don't want to leave out and say, oh, I think it's not benefit. I think at the end, I think the problems when you have the bad news is come very dry. When you have Simplicity Hypertension 3, everybody stop from it. But once you have follow up Simplicity Hypertension 3 with a good outcome, a lot of people don't hear about it. So I think it's have been proved with all the data that's been helped. It could be used as one or two medication, and if you could select the patient, it's much better control. But I think you need to thinking if you run out of choice of pharmaceutical control, or may have difficult or some situation that you cannot control all the times.
Thank you. So I absolutely agree with you. There's no time for discussions. So we move on to the closing remarks. So today, we'd like to thank Professor Ji-Yoon Lim for a fruitful meeting today. And having such a meeting in the Asia Pacific region will be very useful, very helpful for our practice and research tomorrow. So I appreciate to have these meetings. So thank Professor Ji-Yoon Lee.
Thank you. Thank you for all the great contribution of every speakers. Thank you all. Thank you all.
Yeah.
Okay.
Thanks for invitation.
Thank you, meeting you. Thank you. Thank you, Dr. Lourdes and Dr. Siska.
We will finish
yes.
meetings. Yeah.
Yes.
Thank you so much.
Okay, we'll close in. Goodbye. Bye-bye.
Bye-bye.
See you all in the future.